Thank you for joining us for this episode of Crossing Barriers, Building Friendships, a podcast by Peace Lutheran Church in Spring Hill, Tennessee. Our guest today is Randal Lee, who is the Chief Community Recovery Officer at Cumberland Heights. Thanks, Randal, for being here today.
My pleasure, Ann. Thanks for asking me.
I have a number of families in our congregation who have adult children who have suffered or died from opiate abuse. And during the pandemic, while sheltering at home, I read the book, The Empire of Pain, and watched a couple of Netflix programs on the horrible effects of the opioid crisis. So the other night I was laying awake just with a heavy heart, praying. Well, no, not really. I was worrying and thought, who can I talk to about this? To one, be encouraging, or maybe not, because it is really bad. And two, provide some specific steps about addressing this problem. And you, Randal, your name popped into my mind. So I like to think that you were the answer to my prayer. And the very next morning, I reached out to you, and here we are. Thanks again for being here.
My pleasure, indeed.
So I have some horrible statistics, and maybe you can share a little bit more about that. But according to the National Institute on Drug Abuse, deaths from any opioid, whether natural or synthetic, that would be fentanyl, have nearly quadrupled in the last 20 years, and with nearly 50,000 deaths due to opioid overdose in 2019. And back in 2013, there was a huge spike. And in 2018, Tennessee was ranked 13th in overdose deaths, but this surprised me, but number one in opioid prescriptions. So can you tell us from your experience there at Cumberland Heights just how bad it is, not only in just hardcore statistics, but the economic costs, the impact at families, and the increase in infectious diseases and whatever else you may want to add?
Sure, and I'll try to be concise. It's hard to be concise with this because at the level of one family, addiction really brings tragedy. But we also see that addiction moves across the face of the nation in swings and in statistics like you've shared, and that things come and go. 20 years ago, methamphetamine was tearing up Tennessee. It was also about that time, as you know from your readings, that indiscriminate prescribing of opioids became a standard and a practice. In fact, I remember in the year 2000, the Joint Commission was telling us that we had to rate every patient for their pain threshold because their focus was on looking at pain as the fifth vital sign and doing everything and having healthcare providers do everything they could to make patients comfortable. It was the prevalent belief circulated in medical journals at that time that people who had real pain could not become addicted to opioids. And so that indiscriminate prescription began. And all of a sudden we had opioids affecting not just what we may think of as the stereotypical pockets where heroin use occurred, but in families where someone might have a sports injury for a child, or a knee surgery, or a hip replacement. And then opioids were prescribed in large numbers. After that, for the families, in increasing numbers, until the point where they might be cut off for doctor shopping from one doctor to another. And in so many cases, found themselves having to resort to cheaper, less regulated street drugs, where they might be getting OxyContin and they might not. They might, in the last 5 years, we've seen tremendous resurgence of fentanyl, which does threaten to take out a large segment of a whole generation of people in their teens, 20s, and 30s today.
Yes, absolutely. So what kind of effect is it having economically on those of us that maybe don't have an up close and personal contact with someone who's addicted?
Well, almost all of us pay health insurance, and certainly one of the things that we've seen is the tremendous spike in emergency room visits for overdose. And unfortunately, what happens is someone may go to an emergency room with an overdose, be treated with Narcan, which is a good life-saving drug, but it immediately throws a person with addiction back into the throes of withdrawal. So when they're being released from the emergency room, they're generally in a bad mood, not feeling any good, very well at all, and craving the same thing that brought them there. And of course, all those emergency room visits cost us in a number of ways. They cost us through our health insurance. They cost us in access to emergency services when we need them. And naturally, we're coming out of a pandemic where our healthcare personnel have been so constricted in their workplace that there's very small bandwidth in the hospitals to take care of very ill people, whether it's chemically induced or not. So those are some of the costs.
Yes, and I think it also impacts our tax dollars as well. One of the statistics I read said that 66% of patients were insured by public programs, and that's Medicare and Medicaid. Only 16% used a commercial payer. So that affects our tax dollars. I think probably too that hospitals and prisons are probably the two most expensive ways to provide housing for people who are struggling with addiction, and that probably has an impact on us too. What about impact to families and the increase in infectious diseases?
Well, naturally, I mean, you mentioned so many of people winding up on the public insured rolls. And it's certainly easy to see the impact there. I just kind of want to back that up a minute and say, part of my job is to work with people when they're having early stage consequences and before they get to the point where they become unemployed and unemployable or chronically ill because a number of systems are failing. So it's our hope to get people, when they do have resources left, before they get to the point where they have no resources. And often those people are just like the people next door to us. Sometimes they are the people next door to us who are just 5 or 10 years further into this debilitating illness. Naturally, addiction lowers somebody's personal resistance to so many other diseases that can be transmitted. Of course, naturally, people are sharing needles. That's a whole other matter about infectious disease and the spread of Hep C and the spread of other forms of hepatitis and contagious disease.
And AIDS, I hear that AIDS is on the rise too, due to sharing needles and those sorts of things too.
And unfortunately, there is some nonchalance in some of the both drug using communities and in the LGBTQ communities because AIDS has become highly treatable. Sometimes there's less of a perceived risk. So that could be part of why the numbers are going back up with the HIV infection, along with the prevalence of use and behaviors that go with use.
So I know it has a huge impact on families. What kinds of situations have you seen?
Oh, well, can I answer that I've seen almost every kind of imaginable and unimaginable situation possible? I would say that, except that I'm surprised so often. Even though I've been with Cumberland Heights most of the last 35 years, I spent 8 years as assistant commissioner with DCS. What we saw at the Department of Children's Services was, at the time I started in 2003, there were 100,000 children being raised in Tennessee by grandparents. By the time I left the department 8 years later, that number was probably in the neighborhood of 140,000 as estimated by the Tennessee Commission on Children and Youth. If that growth has continued, it's probably 200,000 or more today. So the family fabric is definitely changed and challenged by the roots of the pandemic. We work with folks, every day who are at risk of losing their children or who have lost their children because drug use has prevented them from being the kind of parent they were born to be, desired to be, or capable of being. I've also seen miraculous stories of people regaining custody of their children through recovery, and it's important to remember that too. But often, if it's a 10-mile walk into the woods, it's a 10-mile walk back out of the woods. So this takes time, and rightfully, since small lives are involved, everyone needs to have assurance somebody is on a steady road before that reunification.
I loved how you referred to the opioid crisis as a pandemic. And I wish that as much attention would be paid to this issue as we did to COVID, because it's just as serious of an issue. Can you explore to me what are some of the options available for healing from opioid addiction?
So yes, and to get into that, I also want to talk about the fact that there's naturally a wide, one may hear a lot of things regarding how to get well these days. I think the most important thing is to talk to professionals and move along the lines of getting toward health. It is so easy to get discouraged and to give up, both for people who use and for family members of people who use. So it's very important to stay in contact with knowledgeable professionals. One area that has really transformed the treatment industry in the last 10 years is medication-assisted treatment. There are lots of options out there. I will say I work for an agency that is abstinence-based, meaning that our goal is that people are completely off mood-altering chemicals, and that we believe that's what constitutes solid recovery. But I think it's important to talk about medications that everyone should know about with regard to opioid use disorder. None of those should stand alone in the absence of therapy and working toward a goal of restoration of physical health, emotional health, spiritual health, and community.
I suspect it takes a village, and it's not a one type of approach, but it takes all of those approaches working together. Which I'm just curious, if you could design your own treatment facility, if you were in heaven and could do whatever you wanted, no holds barred, what would it look like for you?
What a great question, Ann. And first, I think every treatment center should have a piece of heaven there. And the most important component of that, I believe, is a healthy staff, a staff that is mission-based there because they really want to work with people affected by addictions. As I used to say when I was with DCS, people who don't want to work with children shouldn't. And I feel the same way about the addiction field, that it's not a place to come get rich quick. That's a flawed notion to start with. So it's for those people who have a calling, either perhaps because of their own personal recovery or having seen the effects in their family, or just having an affinity for the population. So part of having a healthy staff is making sure that staff is supported to be able to regulate their own emotions. Basically, folks are coming to us to get a sense of instruction about how to attain peace, calmness, clarity, and answers. So staff have to have their own calmness, clarity, and answers and be supported in upholding that standard for patients. I think if you start with that, then you can build around that a physical plant or setting, whether it be outpatient or inpatient, that puts the patient at the heart of healing, a place where they feel cared about and where their individual story can be heard and matters. So those are the kind of building blocks that I think are important. Doesn't hurt that we have 168 acres of beautiful land on rolling hills out here by a river. That doesn't help, but it's not the necessary ingredient. First, it begins with people and also begins with that special accommodating, embracing quality of treatment.
So I was really expecting you to say something like not to be dictated by insurance companies about how long you can stay, and some of those sorts of things. The times where I've seen recovery really work, it was like a 2 to 4 year process. It was like in treatment for a year, then kind of at a halfway thing for another year, and then another 2 more years on top of that. And I think that probably sometimes people who end up in residential facilities have made really bad decisions that even getting employed afterwards is tricky because they do so many background checks and urine tests and all that kind of stuff now. So I guess that would be my dream, is that like cancer may take years and years to get over, that we would look at addiction as something that takes years and years to get over too, and just to be willing to embrace that and to do what it takes.
There's a well-respected writer, William White, in the recovery field and in self-help recovery in particular, but in the treatment field, um, who has written eloquently about establishing a recovery-oriented system of care, so that we no longer look as a 30-day treatment as being a silver bullet. And I get it. I work in a treatment center, and yes, we feel our own self-importance, and we feel if somebody comes through our program, we're going to transform their lives. But the best we can do is launch a ship on a transatlantic ocean voyage outside the harbor. So much has to happen along the way in terms of support. That may mean help with housing, employment. Sober housing is a huge piece of that. And as you mentioned, we don't live in a forgetting society with Instagram and Facebook and Twitter photographs and proliferation of Karens. Where if you Google somebody's name, there's always going to be a video of the worst moment they've ever had. That's true for folks who suffer with addiction. And our society has lost the ability to forgive and forget. So we need some way to incorporate some grace for people to make small steps along that transatlantic voyage. And as you say, it does take a village. We need to find ways to support, cheer the small milestones, and make sure that people are accompanied as they move in the right direction.
Well, I was hoping too that you could maybe talk to us a little bit, kind of like Martin Luther, who was, he didn't want to leave the Catholic Church. He just had been in it for so long. And I know you've been in this field for so long and have seen so many things expand and contract. So what would you like to see differently in the terms of residential treatment facilities?
So I think one of the big threats to the treatment industry right now is, unfortunately, there are some people, although it's a very small number of people, who are making a lot of money by buying nice places on the beach and flying people in from all over the country and billing insurance companies very large rates. I think that is a severe threat, that we have some deceptive marketing within our field. And that's something we can do a whole nother segment about. I'm not going to elaborate on that. I do think that's why it's important to know the partners that you're working with, because quite honestly, if there are people who are opening centers just to open a center and to bill insurance, you can imagine that their treatment is not going to be meeting folks in that idealized state we described earlier. So I think that's a huge threat. I think also our field has a reputation for rigidity and saying, it's our way or the highway. You must commit to going to 12-step recovery, which we do believe is the best, that peer-directed recovery is the most effective way for people to recover. But in a lot of treatment centers, it's been very hard to link people in a meaningful way with resources that are going to last after they leave. So I think our field needs to do a better job of linking people to realistic, achievable resources they're going to use, and ensure that they take those first few next steps after they leave the center in an effective way. Our field has been criticized for not providing outcomes for 30 years, and for 30 or more years, we've been trying to figure out how to deliver outcomes. And what really, we have not even succeeded in defining what recovery is in all that period of time. So that may be part of where we need to begin. Common language about what recovery is, an understanding of the barriers for folks coming into treatment, and an appreciation of the natural helpers they already have in their lives that could be leveraged toward their recoveries.
So back to my original concern, it's just someone who was worried about someone who's dealing with someone who's addicted to opiates. What advice do you give? What encouragement can you give? What can we do, not only here on our level, but then to maybe across the country?
First, it's so tempting to want to find someone or something to blame for the addiction. And naturally, a person with an addiction receives the brunt of a lot of that blame. Family members blame themselves. What if I had done this differently? What if I'd chosen that private school? Or what if I had moved to this area of town or whatnot? And usually that's just a shell game. My first piece of advice to folks is, let's take blame out of the equation right now. There's probably enough of that to go around, but let's just pretend it doesn't exist. And let's look at what we can do today in the way of support toward getting help. And anytime someone takes a step toward getting help, we want to reinforce and support that, recognizing that person is probably doing the best they can, even when it doesn't look very good. They're doing the best they can with the information they have and the experience that has funded their life to that point. And we really have to trust that even those things that look defiant or angry or deceptive, those are skills that have kept them alive to a certain point, and they're not going to surrender those skills easily until they have something better to put in place of it. Which again is why a staff that can approach somebody with caring and love when they come in is such an essential part of the transformative process. And when someone with an addiction feels like they are cared for, that can stand as a placeholder until they can begin to care for themselves. The blame and the shame are things to deal with later in therapy and compartmentalize and get rid of. At the beginning, they're not in the slightest bit helpful.
That's good. I appreciate that. And what about, like, is there advocacy work that we can do across the country to kind of, I don't know, I keep thinking like maybe I should write my senator or something. Is that helpful?
Well, it's interesting. There's so many things afoot right now. And just to mention a couple of them, there's certainly across the nation, states are going to decriminalization of drugs, including marijuana. I do believe marijuana is a gateway drug. I do believe that what's funding most of the availability of medicinal marijuana, most of that I do believe is profit minded. Now, I think there are some people, yes, who may be able to benefit for pain relief, and using something like marijuana can keep them from using harder drugs for pain relief that would lead them to another addiction. I do think that's a small segment of the market that the head shops in Colorado are marketing to right now. I think it's much broader than that. But there is something to this decriminalization. When drugs are decriminalized, a few things happen. One is it takes out some of the secrecy, some of the stigma, and some of the hiding of addiction so that people can be more help seeking. That's very positive. So I think the decriminalization efforts, whether or not we believe those are good or bad, it's going to change the equation. Another way it'll change the equation, and this one may be unfortunate, I know some people who sought treatment because they had a drug charge, and treatment transformed their life. They achieved recovery. So one thing we have to do is find what are other motivators that will get people to recovery if legal sanctions aren't present. And that may be family encouragement. I don't know if it's going to be family sanctions, but people have to have a good reason to change their life if they are in a complacent using path that's leading to their own destruction. So I don't have the answers for that, or I would have written my fourth book, and this would be an autograph session. But I do know that the changing public and political will is going to alter the course of how people come into treatment in the future. And I agree with you. Incarceration, in order to get treatment done, is not cost effective at all. And I do believe the outcomes are horrible. And people leaving a correctional center with an opioid history are at greater risk for fatal overdose the first 2 weeks out of that setting than any other segment on the planet. And again, that overdose might not be fatal. It may just mean they engage emergency responders, police and fire to get them to the hospital, incur a large hospital bill, and then they're out again using. And in some cases, I hear, Ann, back in 8 hours or 12 hours to the same emergency room with an overdose. So I don't think prison is the answer or the best possible treatment.
Well, I'm going to give you the last word, Randal. So as a closing statement, what would you like to say?
I'd like to say that I do think the best treatment centers are asking themselves hard questions every time a new wave comes along. When methamphetamine came along, we had to learn differently how to respond to a treatment population with high irritability and a short treatment span, or a short attention span, and also with managed care, a short treatment span. So the best treatment centers are constantly saying, can we be open to medication? Are the therapies we're using working? Would another therapy work best for women? Would another therapy work best for young persons or for the emerging adult population? So I do think that this field is involved in the same lifelong learning that a lot of people are, and adapting as the disease of addiction adapts. It's a very smart and crafty disease. It changes forms a lot, and it challenges us to pull up anchor from what we thought we knew and take a fresh approach each and every month.
Thank you for that, Randal. I'm sure one of the reasons why you popped into my mind the other night is because I know that you have been in this field for eons and have withstood this test of time, not only you personally, but also Cumberland Heights as well. They've been doing good work for a long, long time. So thanks again for being with us today on our podcast.
Good to see you, Ann, and thank you so much for asking again.